And to answer your other question, we did kind of speak after. That was one of our sort of learnings from the first, this was the very, very first clinical work at IW, and trying to coordinate it had its challenges, I think. And I think that was certainly some of the learning that we took was around, like you say, the preparation or being preconditioned to the process. And I think that it was very easy to be skeptical because we didn't understand the process. But actually, now we've come out the other side of it. I think it's a different proposition moving forward. But there's definitely some learning around understanding what we're going into so we can better prepare for it, definitely.
Okay. Thank you, Karen. Thank you, David. Kevin.
Thank you, Chair. Joyce, I'd like to ask a question I ask everyone when there's how did you not move to the solution that you guys in the ophthalmology department felt was the right solution immediately, given the years of experience you've got and being faced with people who have no experience in ophthalmology? It's just one of the things I've always found that I try to go to a solution. How did you manage to stay back from that?
With my arms crossed on the table. And that's exactly what I thought. I thought, why is admin here? What have they got to do with injections? Why is someone from reception? So, but, I sat and listened, and actually the progress throughout the whole week was different ideas, and you think, oh yeah, that could work, and that, but yeah, that's how we came together as a team, rather than, oh, she's from admin, he's from reception. So yeah, say by the time the end of Friday came, my arms were by my side. So yeah, we were a team by that time. So yeah.
Thank you. Zoe.
Thank you very much, Joyce, for sharing the scenario and the project. And I'm from medical school, and we do actually have, apart from clinician, we've got many other colleagues that we are developing and teaching at the university. Means this was exactly the question that Kevin was asking. I'm very interested in interprofessional and inter-team play, and going back to even before people are facing patient, how we can support and make sure that everybody's aware of everybody else's role whilst they are student. Means it would be really nice at some stage when we start having the student to invite people like yourself to come and share a real life stories of how improvement can be done. And as Kevin said, then people can actually see before they get to the workplace how we can actually think outside the box. But thank you for sharing. I've learned a lot.
Thank you.
Great, thanks, Zoe. And I think that's a great idea. And I think Joyce, you said about the fact that actually all sorts of people in the team, the true multidisciplinary team, will have ideas and suggestions. And actually, by broadening the people that are involved, you get some really good ideas. Right, Richard.
Thanks, Anita. My name is Richard Ostrom. I'm in that as well. Thank you very much, Joyce and David, for sharing this. I think it is a fantastic story. Two points from me. One, I wanted to confirm David's point. We had ophthalmology in FPPC a few weeks ago to talk about productivity, and we've really observed a significant productivity improvement. So I think that is partially down to this work for sure. So it's a really positive development. And the second one is for Kevin, really, because this is a great example, Kevin. And the question then, of course, becomes how can we scale this really in the organization and see this in more places, and what's the plan for that?
Thank you, Richard. Yeah, that's a really good question. And so, I mean, we're in the opportune place where we've now been able to get all of our new Kaizen Promotion Office staff certified through the first sort of level of the APIC training program. We have just recently signed off the delivery plan for 25-26, and with the additional capacity we've got a schedule that increases the number of RPIW events over the next 12 to 18 months. And in addition, we haven't touched upon it, but some of the benefit from what we've been discussing is people like David and other leaders in ophthalmology being on our ENHPS for Leaders program. And we're also expanding and have recently circulated the dates for that over the next 12 months. So there's much more opportunity for people to get involved. And in the background, without going into too much detail, we are working across all of the clinical divisions to work out what we call the underlying value streams that are the processes and the pathways that people want to focus next year's improvement on. And out of that work, in future reports to board, I'll be able to share a bit of a flavour of where those areas are and what those RPRWs are going to look like. So lots of work already underway, and happy to bring it back at a future session, Richard or Anita.
Thank you, Kevin. I don't see any more hands up, so let me bring this to a close. So Joyce, David, thank you so much for sharing this. And I think particularly Joyce, your personal account was really powerful, because I think, let's be honest, as others have said, quite often all of us, when we're faced with change, our immediate reaction is to think, why are they doing this to us? What can we learn? And I think actually the fact that you went on that journey and you came out the other side saying, yeah, actually this is really beneficial, I think is really powerful. And I'm sure the team has learned a lot from that process. And it sounds like, David, you've got lots of plans for how you can really implement that and push that through. And as Kevin and Richard have alluded to, what we need to do is make sure we learn from all of this so that all our teams can benefit from that revelation that you had, Joyce, which was brilliant. So
thank you.
Thank you very much for taking the time to talk to us. It was really helpful. So thank you, Joyce. Thank you, David.
Thank you.
Thank you for having us. Thank you.
Bye-bye. Great. Really, really nice when you hear stories like that. Really, really good. If we're happy, let's move on to the next item, which is sort of get through some of the normal admin. The minutes of the previous meeting are in your packs. Can I have confirmation that those minutes are a true representation of the meeting we had in January? If anyone's got any concerns or corrections, if they could let me know now. Again, I don't see any hands raised, so are we happy to take those as a true record? Thank you very much. The action log, moving on to the action log. Stuart.
Thank you. So the actions with future completion dates are on track. There's just two actions to highlight. First is Justin's going to give an update on the preventable deaths. So that one, I'll come back to that in a second, and just highlight for the second one that this is about protected time for BIM Speak Up champions. So just highlighting that we'll keep that one open and bring back a definitive answer at the next board. And if I can pass back to Justin on the preventable deaths verbal update.
Hi, thank you, Stuart. I'm Justin Daniels, I'm Medical Director at the Trust. And thank you for asking this question, because actually it made me go away and do some reading and do some thinking, which is always a good thing. So the origin of the reviews that we do comes from a document sent out by NHSI in July 2017 called Implementing the Learning from Deaths Framework. And this goes through in quite a lot of detail how SJRs are to be done. And it makes the point that each organisation should think about avoidability, but because of the level of subjectivity that you will use in that decision about avoidability, these definitely should not be compared between organisations. So this is very much a tool for using within organisations. It's a tool that you can use to learn outside of organisations, and we now have an ICB Learning from Deaths group, as well as the Learning from Deaths group that we have internally. But the figures that you produce around avoidability are not useful as a comparison. So the answer to the question is that we won't be using these figures to compare ourselves with other organisations. We'll stick to the standard metrics that we get through CHKS around crude mortality, SHMI and HSMR.
Thank you for that, Justin. Thank you, Stuart. Any questions or comments for Justin on that particular point, or indeed on any of the points on the action log? No. Okay, thank you very much for that update. I know that several of the other actions are coming through in the next couple of months, either to this board or to QS, Quality and Safety Committee, or others. So we look forward to seeing those all come to completion. Thank you then. Let's move on. I don't have a specific chair's report for today. As I briefly alluded at the beginning, we are in the situation where Professor Aslanpour will hopefully very shortly be joining us as a full member of the board. As we've said, she's Dean of the Medical School at the University of Hertfordshire. And as part of that, it's part of our transition into teaching hospital status, which we are expecting to be confirmed any day now. And as part of that, Dr. Daniels, Justin, our Chief Medical Officer, will also join the board of the medical school, and that will really strengthen the links between our two organisations and make sure that we really are partners working in lockstep. But I don't have any other reports, so I'm going to hand over to Adam. Adam.
Thank you very much, Chair. So as usual, I've just set out under our 4 key themes some of the highlights to bring to the board, which maybe give a flavour perhaps to some of the data we see in other parts of the meeting. So board members will be aware that our Call for Concern programme that we've been running for a little while now, linked to the work being done nationally around Martha's Rule, is really providing patients where they are concerned and need a second opinion, an ability to ask for that, and an alternative clinician being able to come and provide more assurance. Although we're making good ground with our Call for Concern, there is always learning to be had from others. And Teresa recently took a visit to one of our not too far neighbours down at Barnet to have a look at the work they were doing to make sure that if there were lessons that we could learn from them, we could incorporate it in our work and share that. So we will continue to work across with others to make sure that delivers all the benefits that it has the potential to do. Really importantly, for a number of years now, work has been going on as part of a national programme to consolidate pathology services, so that not every hospital is running a full range of services, but particularly with what is more routine work, that we use kind of a far more industrialised model. We work with all of our trust partners and the primary care activity, and actually the activity that comes through the community and mental health trust to consolidate. And as part of that, we outsourced much of that work to HSL, who are a company with a long track record now of working, particularly from London, with NHS trust partnership with the private sector. A new lab is being opened at Watford, which will supply that routine work for neighbouring trusts. But officially at the beginning of this month, our staff transferred over to the employment of HSL. They will continue to have a presence on our site, as well as working through some of those hub sites. And they will continue to be a valued part of our workforce, as are our domestic staff and others who are provided from another company. The staff have been excellent throughout in making sure that transition works smoothly. So I just wanted to put on record my appreciation for their work in what has been a long drawn out process, but also assuring them of our continued sense of them being part of the family, even though they've moved over to HSL. Board members will also be aware a really important part of the trust vision, matching our desire for consistently outstanding care, is our exemplary service. And we know from the triangulation of data where we hear patient voice, whether it's through complaints, through concerns, through surveys, that actually rather than the core clinical care, often a big frustration is their ability to work through the administration of booking appointments, cancelling appointments, understanding, getting through on the telephone. So just to talk about a programme that Mark is our executive lead on, but with kind of senior operational and clinical input as well, to really redesign the way we do our outpatient infrastructure. So I don't mean the patient experience when they arrive. There's work we can do there, but this is about making sure the things in the background work as smoothly. it's not a case of we or the NHS are terrible and the private sector is great, because we'll have all had some frustration trying to get through to an insurance company or a mobile phone company. But we really want to try to deliver what we're describing as the exemplary service. We will bring updates back to the board at a later stage on progress, but that work is now starting to take hold. We're particularly looking to leverage digital in that to support people being able to get on the phone more efficiently, but also making sure that we really streamline the number of numbers that people might be going through, because often we hear in complaints of frustration where people are just not sure which number they're ringing in. When we investigated, they were ringing a wrong number for the service they were wanting. Under thriving people, it's always nice in preparing this section to really reflect on the number of our staff who are being recognised nationally and sometimes internationally. I've highlighted a few here, areas of awards or new roles that people are taking on. So Jim Adshed, one of our well-established urological surgeons, who actually was very much part of our robotics program in getting that off the ground, has been awarded by the British Association of Urological Surgeons the John Anderson Award. So kind of within peers being really celebrated there. Lucy, our Chief Operating Officer, in partnership with her equivalent at Princess Alexandra Trust, Steph Lawton, is taking on the joint chair of the National COOS network as part of NHS providers. So a really important role in supporting and developing that group of people. I was able to attend the Eastern Region branch of the HFMA event a couple of weeks ago. And as part of the awards, fantastic news that our finance team was awarded the Finance Team of the Year for the region. And Nabiha Sajid also was nominated as the Unsung Hero, Assistant Finance Manager. So really great to see our team recognised. And I wasn't at the awards. I know Martin was there as part of that, but I was speaking at the event the next day and had some lovely feedback from people not in the trust, really recognising that how delighted they were that we had won, because within that community they recognise the high quality finance team we have, and it's good to get that recognition. Also at the same event, we were officially awarded our One Finance Quality Certification, level 2. There are not many trusts that have achieved that. It's a part of a national kind of standard setting. Martin and team have led a lot of work going through that to meet some rigorous standards in terms of being able to demonstrate high quality. So that's fantastic. And just a reminder that we've got our staff awards coming up in July. Always a fantastic evening where we maybe blow our own trumpet a bit more than perhaps we sometimes do, and just celebrate the brilliance of our workforce. The process goes through with various panels reviewing all the applications, but we also have the People's Award, and there is a link in the board papers there for people to go in and to nominate for the People's Award there. In terms of seamless service, I will come back to the board with a fuller presentation when we've made some more strides, but we have set up an acute collaborative across Herts and West Essex, but also including Bedfordshire hospitals. So the 4 acute trusts are increasingly looking to work together across a range of areas that I've mentioned in the paper here. The initial work is being done, particularly focusing on fragile services, to make sure that where we've got services that may be a challenge for sustainability, either because of workforce pressure or financial modelling, to see whether we can support each other through that. Now, this work is being undertaken by each trust, and we're bringing that together over the next couple of months. There is also, though, a framing to say, and where can we have some centres of excellence? So it's not just about propping up existing services, but where can we really deliver centres of excellence where people will look into our place because of our working together. The fragile services work has now been picked up by region, and medical directors across the region have been asked to identify services where there might be some more opportunity. So as I say, we are leading that work from this trust and pulling some papers together, which we will bring back to the board to keep board members updated on that progress. And then under continuous improvement, there's a particular focus here on digital. This month, board members are aware of our One EPR programme, that is our fundamental digital transformation, from which a lot of the transformation can then build and new technology being built on. But it's not in isolation. So very significantly, the new alertive system, which I've described here as a bleep system, but actually fundamentally isn't a bleep system, because we've been running kind of pages and bleeps across the NHS long before or long after the rest of the world has moved on. And this moves to a kind of more mobile phone based model. And we have turned off the bleeps now and use that as our method of communicating. It's far more reliable. It allows more information to be communicated to the right individuals, with also ability to track when responses are made, etc. So a big safety initiative, but also one that is more accessible for all of our staff. And then finally, it won't have escaped board members' knowledge, and the wider public watching may not be aware, the massive effort that goes into the planning round each year. Once the NHS is allocated funding from government, and sets the priorities, trusts and systems, in our case the integrated care system, have to work through to identify how they will deliver the mandated delivery standards, both on quality and performance, within the financial envelope that's going on. Huge amounts of effort is currently going in with a very short time scale, and I kind of want to publicly thank those that are burning the midnight oil, working through that, and working through a very challenging financial framework, because it's not just our own position we need to focus on, but as part of the wider system, making sure the entire system can be achieving the expectations and in financial balance. What has probably not helped or added a new dimension, and my final comment, is that board members will be aware there have been a number of changes in NHS England announced over the last couple of weeks. The current chief executive announced that she will be stepping down, and Sir Jim Mackey, formerly the chief executive of NHS Improvement and currently the chief executive of Newcastle Foundation Trust, will be taking over that in a transition phase that will be seeing NHS England more closely aligning with the Department of Health. There have been a number of announcements of senior leaders leaving this week, including the Chief Finance Officer, the Chief Operating Officer, the Chief Medical Officer, and so a number of crucial roles. There is a gathering of chairs and chief executives tomorrow in London, where some messaging will no doubt be received in terms of what next. So those changes are impacting on some of that planning round, and so we will see what's changed, whether there is a shifting in any of the timescales and deadlines. But it remains, there will not be a magic wand produced tomorrow that makes the challenge will go away. But I think it will provide some more clarity on expectations that we need to respond to. So we will no doubt come back at the next board meeting and update on that progress. We will need to be agreeing our budget during March, and Martin is leading that process to make sure that we can come back to meetings of Finance Committee, board, etc., to sign off our final plans. But that's all I'll say at that point, Chair. Thank you.
Thank you, Adam. Any questions? Jill.
Thank you. Adam, I'm particularly interested in the collaborative work that you've told us about to identify fragile services. And it was just a request really for the timescales for identifying those fragile services, because whatever the reason being that they are identified as fragile, there will be a very helpful role for all of the our assurance committees to play in terms of focusing on the governance arrangements around those fragile services, to provide assurance to the board with regard to, the extent to which we're mitigating risks. Is there a timescale emerging for that yet?
Yes, thank you, Jill. Yeah, there is. In many respects, we did this work a couple of years ago, or actually probably just over 3 years ago, as part of our clinical strategy refresh. So we have that kind of Boston matrix in some respects that we worked through at that time. We are currently going through just retesting that to see if anything has moved to change that position. Our neighbours are I was going to say playing catch up, but that's not intended there behind. They happen to be going through kind of clinical strategy refreshes at the moment. And so there's just slightly different timescales. But what we've agreed is a standard approach, which has been helpful. And Martin may come in and correct me with any of the detail, but the 3 neighbouring trusts are all just concluding that work over the next 6 to 8 weeks. And so we believe that by the end of kind of Q1, we will have a standardised list. Now, what's happening at regional level, and we've only received this in the last couple of weeks, there's been a request to medical directors to pull together what will be a bit more of a gut feel sense of where across the region there might be areas. Clearly, none of that precludes work being done. So we know, for example, interventional radiology is an area that's difficult to recruit to. Everyone can't really do it. We are already in active work with neighbours to say, what is a resilient model that says, how do we work with Bedfordshire hospitals to ensure that our teams can work together to provide resilience? And we know there are 1 or 2 other areas. The gastro bleed rota is a bit fragile across the system. So I think it's likely to lead us to be offering more support in some areas to others. It's about where we have a sense of unified risk, and maybe not a problem now, but when we look at consultant retirements coming up, the pipeline of new consultants, it might be we need to plan now, because we don't want to be in a position in 3 years where everyone's dermatology service, and I'm saying that as a random reference rather than the one that's emerging, is going to be fragile. So let's work on it now to do it. So yeah, initial work kind of timescale 2 or 3. There's going to be some headlines that will drive a regional conversation quicker, and I think we'll be probably able to bring something back, maybe not the next board meeting, but the following board meeting.
Lovely.
Thank you, Jill. Thank you, Adam. Any further questions or comments for Adam on his report? No? Thank you very much. That's great. Let's then, we'll accept that report and move on to Justin, introduction of smoke-free sites across our trust. Thank you, Justin.
Thank you so much, Anita. So, as everybody knows, in the UK, just under 13% of adults currently smoke. Unfortunately, half of them will die early because they smoke. That means that in 2019, there were just under 75,000 deaths in the UK that were attributable to smoking. That's roughly 1 every 7 minutes. 500,000 hospital admissions each year are also directly due to smoking. And that means that for Eastern North Herts, that's roughly 10 of our admissions a day are directly attributable to patients smoking. We know that our hospitals are built to care for those who are sick, but also to promote healthy behaviour. And it's therefore unacceptable that as a hospital we have measures in place that normalise smoking, such as dedicated smoking shelters. So what we want to do is we want to follow where a number of other trusts in the UK have gone in terms of promoting their sites as smoke-free. The paper I'm presenting has been approved at Quality and Safety Committee, and I've brought it to board for discussion and hopefully for approval. What I've also included in the pack is the updated smoke-free policy for the trust. And what this describes is the support that we're putting in place, both for patients and staff who currently smoke, and the changes that we want to make to the organisation. And if that's okay, I'm going to stop there, and I'm really happy to take questions.
Thank you, Justin. Any questions for Justin? Richard.
Thanks very much, Justin. I'm very supportive of this proposal. I have just one question, really. Is 2 years not too long to evaluate the option A? Because there's more and more evidence, not just that young people, we achieve the opposite with young people doing vaping, but also the negative effects on health more direct from vaping. So that's really the question.
So you wouldn't be surprised to know I've got quite strong views about vaping. Vaping was very much touted as a way of helping people stop cigarette smoking. For every 1 person who stops cigarette smoking, 40 young people have been introduced to addictive nicotine via the vaping process. And increasingly, we're seeing the companies that produce cigarettes now producing vapes. This is not great. The initial research in the UK said that vapes were 95% safer than cigarettes. We now know that a number of people who were part of that consensus group were in some way conflicted, and we know that that's probably not true. However, the national policy is still that we promote vaping as a way of quitting cigarette smoking. There will be a number of changes to that later on this year through the vaping and smoking bill that's being brought through the Houses of Parliament. So, for example, we're expecting to see disposable vapes being taken off the market in the UK, which I think is a real step forward. We're also expecting to see that flavours and colours that are particularly attractive to young people being removed from the market. I think we have to follow the national policy to some extent on this. And I think it's probably unreasonable at the current time to expect our patients not to vape and our staff not to vape. However, I want that to be in a designated area on site rather than having it all over the site. So I absolutely agree with you, and I absolutely support you, and I think the scientific evidence supports you. But I think to some extent we have to follow the national policy whilst we make this change. But that's why we've made it clear in the policy that this is an interim step to allow vaping on site, and we hope shortly to be able to stop that as well.
So my specific suggestion was to reduce the 2 years to 1 year, Justin.
Can we see what happens to the national policy on vaping? Because if the policy remains swap to stop, then it's going to be really difficult to work with the local authority and to work with the other statutory agencies we need to work to do this. I'm certainly not unhappy about reconsidering the 2 year idea, but I think I'd like to see what happens with the national policy first, if that's okay.
Thank you, Justin. Nina.
I actually just wanted to second Richard's point, actually. I think with everything that's moving with the evidence, this will be no surprise to you, Justin, because I'm always talking about vaping. But obviously with 2 teenage daughters, I really see that it is so accessible for young children. And so it is just a ticking time bomb. Those vapes aren't, regulated in the same way that we do with cigarettes. There's so many issues with them. And I agree with Richard. I think there should be maybe just a little review in there, even if you just go away and do it just after 12 months, because I think the evidence is going to start to come through. And it would be great if we were a little bit ahead of the curve on this one, because, we do have quite a lot of young people in Hertfordshire that are kind of coming up through the schools and stuff now. So I suppose I just wanted to second Richard's suggestion that we review it in 12 months.
Okay, I think I'm hearing a really strong steer on that. I'm happy to change the plan and to review it in 12 months.
Thank you, Justin. Diana.
Justin, I was just reading the paper where you talk about that around the impact section, that there'd be a need to engage with patients, carers, visitors and staff. I just wanted to kind of get a bit of an understanding about how that engagement is happening, because obviously different approaches are needed for different groups. And also I'd like to understand in terms of impact, will you be breaking that down to look at different groups? So for example, people from poorer backgrounds, what kind of impact this policy is going to have on them, and will that be involved in the evaluation?
So smoking is the single biggest cause of health inequality in the UK. It's the thing that makes the most difference. And the poorer the background you come from, the more likely you are to smoke, and the more likely you are to lose years of life because of smoking. So we absolutely have to look at it through all of those lenses. We've got a specific offer to patients who are already in hospital of the different things that we can offer in order to deal with nicotine craving, because smoking is an addiction, and that's very much how we have to view it. There are also things that we can offer to our staff in terms of helping them to stop smoking, and certainly to change from cigarettes to vapes, although, as we've just discussed, vaping is not a great thing to do. So I think we have to look at this through all of those lenses. I guess one of the things that shocked me the most was when I sat down and worked out the numbers for this. The idea that 10 of our roughly 100 admissions a day are due to smoking is just utterly shocking. And if you look at the number of deaths we see each year as an organisation, actually a very significant proportion of those are also due to smoking. So we absolutely have to change this, and we have to get this right, because this is a really important part of our health inequality strategy.
Thank you. Kevin.
Hi, I support everything that's been said. I would, however, like to ensure that we identify the implementation of this as well on the site. So it's not going to be difficult. It's not going to be easy. In 2007, when this was introduced, if the government had stuck to their guns and done it around hospital buildings, we wouldn't have the problem that we have at the moment. And this is a mismatch at the moment. And my concern is we are a hospital. We have people who are hugely stressed, and a lot of people turn to smoking while they are stressed. So I have to say this, whilst I appreciate everything with that, we need the law on our side definitively, so as we can challenge people smoking on our site. I don't want to see challenges made by anyone other than security who are trained in this, and then risk the chances of assault, which has happened on numerous occasions. Someone being told at a moment of great stress in their family or anything else that they can't smoke when they're out in the garden does tend towards aggression. So I'd like to take that into consideration as part of the ongoing requirement for us to actually implement this. And it's not as easy, although I do support and appreciate everything that's going on there.
Thank you, Kevin. There's lots of bits to think about in a response to that. Just to make clear the legal position, in Scotland and Wales, it is currently illegal to smoke on a hospital site. In England, it is only illegal to smoke in a hospital. I put this as a question to the Chief Medical Officer at a recent conference on smoking, and I was assured, as were the rest of the audience, that this would change shortly. And I'm hoping to see that come through the smoking and vaping bill that's currently going through the Houses of Parliament. And I completely agree with Kevin, that would make our legal position on this much easier. However, 2/3 of trusts in England have declared that they are cigarette smoke free, and are doing work around that. I think that the second issue, Kevin, that you bring up is the difficulty in talking to people, rightly, as you're saying, going through a stressful time, and how you talk to them around this. And I've seen this done in a number of different ways at different organisations. And it's very much about nudge and understanding and explaining, rather than lecturing and confronting. And we're going to be doing some of the communication things that will help us with this. And we've got a number of other ideas of things that we can do. So, for example, some trusts have pictures up of young people going to asthma appointments and saying, please don't smoke around the entrance to our hospital. Other organisations use tape recordings that explain why this is important. And we're going to be going for a number of these things as we think about how to do this in a way that takes people with us, rather than getting their backs up and causing confrontation and causing difficult issues. Interestingly, a number of people who smoke on our sites are neither patients nor staff, but are contractors towards the organisation. And we're going to need to make sure that it's very clear to them that smoking is unacceptable on our site.
Thank you. Tom.
Hi, thank you, Anita. I just wanted to assure the board around kind of actions in terms of staff, because we need to recognise this shelter is not just used by patients or members of the community. Significant of people that use that shelter are our own workforce and our colleagues. This, Justin's work has been very much aligned with our Health at Work team, and how they are supporting smoking cessation amongst our staff. So there is accessibility for people to contact the occupational health team and provide the right sort of support and counselling and coaching to be able to help with their nicotine addiction.
Thank you, Tom. That's helpful. I think this has been a helpful discussion. I think what's been very clear for messages that there is very much support for this. this decision, some sort of impatience in that we would probably like to go faster than the 2 years in terms of reviewing the position on vaping, recognising that there are some legal constraints, but perhaps it would be possible for us to review this in a year or so. It's also been helpful for us to confirm that in terms of the, if you like, enforcement of this, it's going to be more carrot than stick. We're going to try and encourage and persuade, but that our security teams will be briefed to support that initiative as well. I had only one question which didn't come up so far, I think. Do we have, in terms of our workforce, do we have any idea what percentage of our workforce might be affected by this smoking ban?
Really good question. So I don't know the number, but one of the things we've done as part of the group looking to implement this policy is we've invited somebody who's a member of staff who actually smokes onto the group, because we thought it would be really helpful to understand their perspective. I would guess that we're largely representative of the area that we serve. Hertfordshire has a very slightly lower smoking rate than the rest of the country. It's currently sitting at about 10%. So my gut feel would be that probably 10% of our staff would smoke, but I don't have that number, and we don't ask people to declare that in any way, shape or form at work. So it's not data that we would readily hold.
No, and I appreciate that. I was just wondering in terms of making sure that we've put sufficient resource into the support framework around those patients, really, because if it turned out to be 50% of our staff, for example, it might mean the resources we needed were greater. So this is a decision that has been passed by our management group, and it's come to board because this is a significant step in our journey to try and really tackle health inequalities amongst the population we serve and our staff. And I'm asking, it's for discussion, but I'm asking for board agreement and support for the decision that has been made. Do I have that support, please? Thank you very much. And as I say, I think this could be a really important step on our journey. So thank you to the team for having worked on this. Right, moving on. Let's move to our strategic goals refresh. Kevin.
Thank you, Anita. My name is Kevin O'Hart. I'm the Chief Kaizen Officer at the Trust. The paper in the pack outlines the process for the annual refresh of our strategic goals, which in a few moments I'll be asking the wider board members to discuss and agree the proposed changes before we begin the onward cascade across the organisation. I've also included a brief summary of some of the intended improvement activity that we plan for next financial year in response to these goals. And I'm just noting that there's an additional paper scheduled for May board where I'll bring back a summary of improvement and achievements that we've undertaken in the current financial year to meet our current strategic goals. In terms of the process we're using, this is a tried and tested method. We're working alongside our improvement partner, Virginia Mason Institute, and we're really tapping into their learning and experience over the last 20 years plus in developing a successful model for this alignment and cascade of the vision, strategic goals in an organisation, where they've been able to really demonstrate a significant impact on staff engagement and motivation, which then has correspondingly had a significant positive impact in terms of staff satisfaction levels, which in turn has obviously had the impact on improved patient outcomes. And that's been successful year after year. And that's part of the reason why we want to adopt some of their learning there. For me, this is really how we begin to engage and motivate all of our 7,000 staff using this strategic alignment process, using the Grow Together conversations and the golden thread into our improvement method, the Eastern North Arts production system. So we create an environment and a culture where all 7,000 of us are working towards the same end and the same goal for our patients, our staff and our communities. And for me, it really builds on the essence of what ENHPS is really about. Because as we've talked about with the ophthalmology rapid process improvement workshop earlier, if you look at every member of staff looking at the processes that they look at, and if everyone is looking to improve those processes, and even if you reduce each process by a few minutes, but if you think about those processes, how many times are they replicated by one member of staff every day, each week, every month, and then you multiply that amongst 7,000 staff. You can really begin to start seeing how you can build up, by reducing waste, additional elements of value and time that we can then redirect into patient care or reducing the burden of work for our staff. And that's the power that we're trying to harness with what we're doing here. I think for context for some of the new NEDs around the table, we have quite subtly but deliberately in the last 2 years moved away from what we would probably say were quite top-down strategic objectives or initiatives that were quite targeted to selective areas, be it around maternity and USC. And we've seen really powerful and impactful improvements and changes in those areas. But I also think that we heard from teams that they sometimes struggle to understand how they could relate into those goals. And so we have deliberately started moving towards multi-year broader goals that are framed so that regardless of where you work, what role or what function that you do, you can really begin to understand how you can contribute towards delivering the trust vision and work towards those goals yourself. So I think what I would say is this review process wasn't necessarily undertaken to rewrite our existing goals. It was really much more about ensuring that they were still fit for purpose. The paper outlines some of the processes that we undertook, including an internal and external environmental scan, where very much the importance was ensuring that the current goals were still aligned to regional and national changes in policy, and there's been a lot of movement in them, so that's been a very important piece of work. We then moved into a large engagement event back in November with 90 or more of our senior leaders from our divisions and our care groups, where we played a bit of catchball. As an executive team, we played back and sort of described what things looked like for us. And we had a two-way conversation and feedback from divisions about how that resonated and was that still meaningful for them, so that we could build their feedback and understanding into this process. And that starts the real ownership of the goals moving forward and how then those teams begin to cascade in their own areas. I'd probably reflect, and many of us will have done a number of positive leader rounds in the last couple of weeks and months, that progress and cascade is variable. I would reflect that you can definitely see that we have started to see much more insight move from senior leadership and management levels to the middle leadership levels across the organisation, but perhaps not so clear in some of our local management leadership levels. When you have richer conversations and you start digging into things and you start understanding what people are talking about, the kinds of improvements that people are doing, you can so see how everyone is working towards the current goals, but it's just that the explicit links are not yet at the front of mindset of people at the moment. And from my perspective, in terms of organisational change, that's fine. We are in the messy middle and we'll continue to be in the messy middle of change for the foreseeable future. So the new way of doing things is not yet established and embedded as day-to-day customer practice, and that's going to take time to adopt and spread. One of the key ways we do that is the ongoing expansion of our ENHPS for Leaders programme, and I've talked about this at previous board. We already have 90 senior leaders gone through the first 3 cohorts of that programme. We have a similar number of leaders that will be going through that programme in the coming year. And not just does that provide people with much more understanding and knowledge and skills around the improvement message itself, not only does it talk about coaching to move us as leaders, as fixers to leaders as framers, but we also do a lot of coaching around what we call advanced daily management. And that is the element of how we build the improvement infrastructure within all local wards and departments across the organisation. And a lot of that feels and sounds quite familiar around production boards, huddles, lots of visual management. But what this does is there's just continual day-to-day reminders, visual reminders that links day-to-day work with that strategic goal and the improvement work that each team are undertaking as part of their day-to-day job. So just to sort of conclude, the output from this wider exercise is summarised on page 56. What we are suggesting and recommending is that the current goals are still fit for purpose, but listening to people and feedback from staff, we want to maintain the essence of those goals, but with a much more simplified wording, which we feel will make it much more easier to understand and translate those to individual teams across the organisation. And at that point, I'll probably stop and ask for comment and approval of the goals, please, Chair.
Thank you very much, Kevin. Teresa.
Thank you, Chair. Kevin, I just wanted to say that I think at this stage, through my lens, it's okay that the whole movement around improvement is variable in some ways. But what I'm seeing in my rounds is a real ambition and drive to get that sort of process realignment, standardisation, so that staff are freed up to make sure that the patient care is much more bespoke. And I'm seeing that in the antenatal ward, the respiratory ward, the children's ward and AMU RAID, a real ambition to make sure that the production system and the strategic goals are aligned. So I just wanted to say if there's more we can do on the nursing and midwifery side, please do signpost us to that. But certainly an appetite to make this work.
Thank you. Richard.
Thanks, Kevin, for this. I think I understand how this fits in the overall, let's say, strategic framework and what you're trying to achieve. I don't want to get stuck in terminology, whether these are goals or objectives. I really see them more as strategic direction than anything else. But whatever we call it, I think there is a need for how do we measure success? And that's what I'm really missing here. So could you comment on that?
Yes, definitely. So I think that is something that we have kind of talked about as an executive team in our conversation, indeed with the senior engagement group. I think the idea is very much that as these goals or objectives, and I take your point to hand and we can take that offline, as they cascade down into, to start with, the divisions, that there's a need to get much smarter then in how the divisions translate their intended improvement work so that they are much more measurable. And then that cascades down the organisation so that we can very much meet what your expectation there is and be able to identify in advance what those objectives and outcomes will be and in a quantified way and evaluate feedback on that. That is still a work in progress. And I think as we go into the second year, our reflection and the conversations in November with divisions of care groups was there was almost a reframing of the strategic goals at trust level, at division and care group level, and the focus next year needs to get into, but what are the more smart, quantifiable things that you are going to do that we can measure? I will bring some of that back to the report in May, where not only are we closing down 24-25, but we can perhaps provide some assurance about how they will become more smarter so that you can have that assurance moving forward, if that's okay, Richard, and answers your question for now.
Thanks, Kevin. Thanks.
Thank you. I thought I saw Karen a minute ago.
I put my hand down, Anita, because I was going to ask the same. It was the same type of question as Richard, and in his answer, Kevin has effectively closed.
That's fine. Thank you. Sorry, I just thought I was hallucinating for a minute. That was all. Janet.
Thanks, Anita, and thanks, Kevin. Yeah, I've got I was going to ask that question, but I was also going to ask a supplementary question, which was around the description of the leadership interventions. And I think in your report you talk about boundaryless leadership, which obviously is a great aspiration and really allows us to start cascading that kind of learning and really pushing the impact of sort of change champions across the different divisions. But I guess my question is, A, how will you measure the impact of that? And B, how does it align with the sort of broader leadership offering that the organisation has? Is it kind of a module of it that's delivered separately? Is it completely separate? Or is it actually, yeah, that was a question. And the other question was around the EDI piece in the document. The EDI steering group is still very, very new. And again, I think having a really good baseline around what do we think the EDI issues are in terms of this area of the trust business. And is there something about kind of setting some sort of baseline that the EDI steering group and also then the People and Culture committee that I chair can start to track some of that impact?
Thanks, Janet. And I'll probably sort of look to bring in my colleague Tom in a moment to answer some of those things. What I would just say from a more general perspective is there is good alignment between the people team and the different leadership offers and the leadership program that we're running out of the Kaizen Promotion Office for ENHPS. And we're very mindful and careful that they align and supplement one another and signpost one another and come together without duplication to provide the right leadership training and coaching for teams as we move forward. The program that you refer to in the pack is part of the organisational development leadership program following the divisional operating model review and consultation process, and that's now sort of up and running and probably moving towards the sort of the third team day schedule that Lucy has been supporting with Justin and Teresa's sort of input. It's been really mindful that rather than just thinking as probably previously in the organisation that you can make structural changes and bring multidisciplinary teams together and expect them to work, you can't. You really need to coach them and give them new skills and mindsets to think differently for how they can come together in a really sort of more meaningful and impactful way. But I think, is it okay, Tom, maybe if I ask you to, because if or you or Lucy maybe want to add more either onto that kind of leadership program or the EDI element that Janet's referred to?
Yeah, I mean, I think you've really said it, Kevin. I mean, just to assure the board, it is absolutely aligned. We've got, certainly Steve, who's coordinated some of the work, Catherine in Lucy's team, but also Catherine in Kevin's team have all been working quite closely around how we're making sure these things are aligned. Obviously, there's still some of the, as the leaders course starts to roll out and more people go onto that, it will be much more embedded across the organisation, and we can only go so fast as those cohorts go through. But we're being really careful not to do something that really takes us off in any type of different direction for the time being. So, I mean, I think, Kevin, you said it really.
Thank you. I had just one question, or whether I'd be interested in your thoughts on this. I mean, one of the things I was really pleased about was the efforts we made to engage, and those engagement events which were very well attended, and to really get our people's views on our strategic goals, objectives, whatever we're going to call them. I'm interested as whether. It's interesting that at the end of the day, the conclusion was actually we're broadly right and people are broadly still aligned to what we currently have. Were there any interesting ideas emerging from those engagements that were things that perhaps didn't make it this time, but might tell us something about the future direction of what our people might think our future goals ought to be? Adam, is that to come in and answer my question? Thank you.
Yeah, so I think it's a bit of a self-fulfilling prophecy, because there was a fair bit of engagement previously, so it wasn't as if we'd done something in a darkened room and suddenly launched it on the next level who looked at it. There was far more of a nuancing, actually, and I think one of the lessons we learned from a couple of years ago is where we had done some initial brainstorming and kind of have flip charts, and then people went round and reflected. The trouble is we designed it by committee, and we ended up with some pretty long goals because you got every little bit of nuance in there. And the clear message and reflection was that we drifted away a bit from the original intent. And I think what we've taken a bit of a challenge, including some AI input. Actually, we put the goals through AI that came up with really punchy messages, but then the feedback from the teams where it was too punchy and it didn't really cover the narrative. So I think where we've landed on here is not so much the content, because I think it landed very much in the place people were, but as Kevin touched on, it's really finding that right level where these kind of strategic goals become in-year objectives. And we perhaps went into it first thinking divisional level, we'd get a bit more bite, but actually the reflection in the conversations played back were that even in a division, those goals will look very different across paediatrics, neonatal, maternity, gynae. So actually it's that care group level where you really get to the point of saying, for us, this is our big plan this year to move that forward. So I think that's where we got some of the nuancing, but I don't think we heard anything that came back and either jarred or made us think we really need to spend more time thinking about this the next time. So it felt very much aligned. Now, I think the learning this time, as we said, as we now iterate this further into the organisation, we might get some rich learning from care groups and below, staff saying this still doesn't really talk to me, but for us, surely this is the big priority. And then I think we can play that back. So each year, and again, when I probably went in, if I'm all honest, thinking, I really want us to have this crack within a couple of years, and the clear pushback from Virginia Mason Institute was they've been at this for a decade and it keeps getting better, but it's not there yet. So I think there is something that we have to recognise with 7,000 staff and not just 7,000 staff, but if we've got 10% of our staff coming every year, there's an awful lot of new people that we need to keep getting before we touch everybody.
Yeah, thanks, Adam, and that's helpful. And I think you're right. I think these things are always iterative, and actually we get better as an organisation at doing this as well. So no, completely agree. Okay, thank you very much. If there are no further comments from or questions from the board, this paper was for discussion. Assume we're all happy. Let's then move on to 1EPR. Mark.
Thanks, Chair. My name's Mark Stanton. I'm Chief Information Officer for the Trust. So taking the papers as read, my main update really is around the governance. The programme is very much in its design phase. We've just stood up the new governance, and I think that we know from history, not just in this trust, but other trusts as well, is that you absolutely need to get an EPR programme right. It's about clinical engagement and it's about adoption. So to that end then is that in terms of leadership of the programme, along with myself, is that our senior leadership team is now a CCIO, who's a consultant surgeon, a chief nursing information officer who's obviously a nurse, and we've also got 10 clinicians who are now either full-time or part-time attached to the programme, so a mixture of doctors, nurses and pharmacists. And all of that is then supported by a robust governance. So we've got 6 work streams, and each one of those is chaired by a clinician. We've got a programme board that's chaired by myself, and we've got a number of steering groups as well that hold all of this together, along with the clinical design and the technical design of the programme. And what's going to sit above those is a NED-chaired board committee that will bring for approval to the next board, but it's very much in development at the moment, and the first meeting ready to go ahead. So a really robust piece of governance around that. In terms of the programme, we're targeting a October go live date for phase 1, and phase 1 pretty much is unplanned care with a few other pieces of functionality. We haven't published that plan yet. There's still a number of risks that need mitigating. So in the next week or two, we'd be looking at publishing that plan with very clear delivery dates for both phase 1 and phase 2 of the programme. So I think I'll leave it there and open to questions.
Thank you, Mark. Any questions or comments for Mark? Richard.
Yes, thanks, Mark, and clearly support what you said about the whole structuring of the program and the governance structure. But you also asked to confirm whether the PMO-generated papers are appropriate for FPPC reporting. I'd like to defer that to the start of the new committee that you've been discussing. And I've got a question for you, which is, I think, critical for the readiness in October, which I think we'd all like to see, is the availability of the software. And is there any more news on that at all?
So the software is due, the kind of the current product is due to be delivered on the 17th of April. That's the date. I'm still waiting for 100% confirmation on it, and that the whole plan is triggered on the 17th of April delivery date.
Thank you. Teresa.
Thanks, Chair. Mark, it's great to hear that the nurses and midwives are and the doctors are fully engaged, but I didn't hear AHPs, and I'm just really keen to make sure that their voice is heard and seen in the development and implementation of this programme.
Yeah, so the AHPs would be included within the work streams, and also is that the CNIO has got a team, and one of that team is an AHP. So we've actually got that expertise directly within the digital team as well.
Brilliant, thank you. Ailey.
Thanks, Chair. And I was just going to add to that, we are developing a really comprehensive communications plan, which really breaks down the audiences into quite specific groups so that we can make sure that for every sort of milestone or bit of development of the programme that we are engaging with the right groups at the right time. And that does go right down into the level trees of AHPs. And, you know, there will be their engagement, but how are we making sure we're getting the messages to them at the right time in the way that they prefer to receive it and will receive it best. So we've got a really granular communications plan that's nearly finished.
Thank you, Ailey. Janet.
Thank you, Chair, and thanks for this information, Mark. It's really helpful, and it's good to hear that we'll be getting the committee of NEDs, etc., up and running shortly. I had one question, which is, given that the software you're expecting it to be delivered in April, and the first tranche of go live is October, are you confident you're going to have enough time in terms of testing and training to hit that deadline?
Yeah, so assuming that the software is delivered on time is then that we have got time for all of those activities.
Okay, how much would it have to be delayed for that to be an issue, do you think?
So I think the plan is tight, and I think that if we were to push into the following month, then that would have a significant impact. But there's a number of items that we still need to just clarify before I'm kind of confident to say October is the go live date.
One of the things that would be helpful, I think, for future reports is to have a critical path, so we can just understand that in terms of whether there are going to be issues around timeline, because there's a lot of information in here, but it doesn't necessarily give you that detail.
Yeah, and I think the intention would be is that there will be a plan published with all of those activities on it, and that I would intend to bring to the board committee. I would bring that plan for scrutiny.
Okay, thank you.
Thank you very much. I don't see any other hands up. This paper is for discussion. I think we've done that. Thank you, Mark, for that update. That was very helpful, and we look forward to the setting up of that new committee, because I think that will really help reinforce the governance that we've got around this really critical project for us. Thank you. Right, I think I would like to propose a 10-minute break at this point. So I make it 10:52. So could we please just get a quick 10 minutes, and at 2 minutes past 11, we'll start back with the rest of our agenda. So back at 11:02. Thank you. Welcome back. So let's carry on with our agenda, and the next thing we have up is our integrated performance report. So I can't remember who kicks this one off. Is it Martin? You start it.
It's a different test you give me every time. I need to.
Oh yeah, I could never remember. Sorry.
Yeah. So hi everyone. My name is Martin Armstrong. I'm the Deputy CEO and CFO kind of here at Trust. This is our integrated kind of performance report item that presents our performance against kind of key metrics, both nationally and locally determined across kind of 4 key domains: quality, operations, finance, and people. I think in time-honoured fashion, we'll just kind of move around those kind of domains and invite kind of executive colleagues just to give a little bit of a kind of summary, perhaps concentrating on page 68 of the pack, which just really acts as a little bit of a summary guide kind of for us. So Teresa and Justin, can I ask you if you could lead us off in terms of quality reflections, please?
Shall I make restart, Justin, then hand over to you? Would that be okay? Thank you. So I'll take the report as read. Thank you, Martin, and just draw out a couple of highlights, if I may, most of which are in the summary. So our infection control record to date looks relatively stable. We are under trajectory for our C. diff count for this time of the year, but anticipating that next year we'll see a reduction in that as well. We have seen an increase in the number of instances that have been recorded through NHANS, and that is in line with best reporting practice. So people are telling us, staff are telling us something has happened and they're recording it. So we're very pleased about that. We have got 2 PSIs that are underway at the moment. One is jointly shared with HPFT, and the detail is in the pack there.
With it, but I was a little bit concerned because they do seem very, very stretched. They are extremely efficient, and almost in a way these figures hide just, you know, the pressures that they're under. I'm just wondering, are there things that we can do in terms of being able to support them a little bit more? Because, as I say, they do seem extremely stretched there.
I'm ever so sorry to butt in, Chair. Do you mind if I just explain? We've just had a power outage of some description, which I'm getting a report on, which means it's knocked a few people out with regards to the Wi-Fi. So Martin has had to restart his computer, so there might be a few people out, and I might just have to leave for 5 minutes, if I may, just to check what it is. But just to let you know what it is, I'll leave my computer running so Martin can come in here. I don't know why mine isn't, his isn't, so my apologies.
Not at all. Thank you for letting us know, Kevin. That's helpful. Sorry, Teresa, did you want to come back on the PALS point, please?
Yes, please. I think, Dana, these are really valid points that you make, and there are 3 things I think that are really important around how do we change the sort of traffic going through PALS. They are a great team. They do work very hard. Number 1 is trying to prevent the complaint at source and trying to understand where the, if you like, the high volume complaints and concerns are coming from. And I think that really sits largely with the divisions. Sometimes it's corporate teams as well, but making sure that they're aware and that they feel that that's part of their core objectives is to prevent those concerns and complaints and really manage them. So what are we doing about that? We're working with the divisions to really get that ownership in place. We've also invited Paula Statham, who's our Director of Cancer Nursing, to lead on patient experience, which she's going to be doing for the next 12 months. And part of that supportive role is that she's going to chair PACE, but she's also going to be actively involved with myself around how do we get some senior nursing support embedded in PALS, because I think that'll make a big difference. And the third point that you made so brilliantly is around how do we get some support in immediately. So we are looking to use our Pathways to Excellence team to try and get some support in no later than the 24th of March, hopefully, Dana.
So that all sounds great. Thank you, Teresa. I don't see any more hands on quality, so I will try and move on to operations. And Lucy, thank you.
Thanks very much, and apologies for the network outages. Several of us got chucked in and out of the meeting, and I hope it won't happen again while I'm talking. I'm Lucy Davies, Chief Operating Officer. Just highlight for you 3 areas in operations this month: urgent and emergency care, referral to treatment waiting times, and diagnostic waiting times. So urgent and emergency care has been moving up in terms of our performance, and the month reported on here is January, where it went up 3 percentage points from the performance in December. It stayed similar in February, and I'm really glad to tell you that in March we've jumped up to 77% month to date, which is a massive step change. I will say we've been here before with boosts in performance that we don't always manage to sustain. I'm more confident this time, but I'm not making you promises about how we'll finish March or indeed April. But we do now have an underpinning urgent and emergency care improvement programme Mark II as a follow-on from the first one that we discussed in detail at FPPC and through this board. And people at the front door and on wards, particularly ward managers, are really engaged in a way that I've not seen before. So watch this space for continued improvement. On referral to treatment waiting times, we have, while not forgetting our backlog and important work to continue to reduce the backlog, we are turning our attention to our performance within 18 weeks in line with government directions. And we have been improving on that front for the last 6 months. So we've improved now to 61%, which is slightly ahead of the national level, which is about 58–59%. And our target for next year will be 65% by the end of March 2026. That's challenging in the light of no additional funding for elective recovery anymore in planning terms, and will be supported by lots of detailed work going on clinical productivity to support the continued improvement without as much money as has supported it in the last couple of years. And on diagnostics, excluding audiology, where we're continuing to progress both capital and people plans, and we're now almost fully staffed in the audiology team. But excluding audiology, where we are tackling those particular problems and a number of pathways remain closed but on the track to getting back open, we have reduced diagnostic waiting times over 6 weeks by over 4,000 patients since April 2024, which is 43% improvement. So it is a month-on-month improvement due to really focused work supported by the PMO team and the ops and clinical team working shoulder to shoulder together on efficiencies and improvements in all imaging modalities and in other diagnostic modalities.
Thank you, Lucy. Now, David's has already told us, but before I come to him, I wonder if I could come to Richard as chair of FPPC, if there's anything you'd like to add or comment on Lucy's report. Thank you.
No, we've highlighted some of our concerns in the board report, which is there for discussion a little bit later on. So we can do that. I think Lucy highlighted the most important points.
Thank you, David.
Thank you, Lucy. We know, and you've discussed it, that we have MRI capacity gaps. We know that you have plans. I guess what I want to emphasise is that patient demand will continue to go up, and inevitably the number of scans requested by our clinicians has gone up year after year after year. So I'm just a bit concerned that we're inevitably chasing a moving train. And why am I concerned? Well, serious things get worse while you wait. There's no doubt about that. And as a patient who's been on a cancer pathway, and even though I knew the chance of cancer was only 10%, I found it quite worrying sitting there waiting for my next test. So we just want to, I want to acknowledge that. So my question is, are our plans sufficient? Will we have enough capacity, and will we be able to put enough people? Can we get as many people through the MRI machine as possible, so that we can be confident that this number will drop?
So we have a really fantastic demand and capacity planning model in this hospital, in this trust, I should say, and so our demand and capacity plans are always worked through to a very, very high level of detail, and it's on the back of those that the MRI business case, which is being finalised at the moment, is based, and it does, look at not just a static model of demand, but the growing model of demand. So while we can't fully predict how it moves in the future, it's not just predicated on, a kind of assuming that the level it's got up to now flattens, because we know that's not realistic. In terms of being able to recruit sufficient staff, the case involves a different staffing model, and particularly opening into the evenings, and does look at a slightly different model of staffing in terms of some banding of some of the staff, and that's been done alongside colleagues in Princess Alexandra Hospital, where they've worked on their particularly radiographer models and banding. So we expect our offer to be competitive within that market, but these are challenged specialties to recruit to, so there aren't easy answers. We may have to continue to run a mixed model of outsourcing and improving our own service.
Thank you, Lucy. Jill.
Thank you. Lucy, it's really wonderful to hear of the more recent positive trajectory improvements with regard to urgent and emergency care, and your indication that there's a much increased engagement from clinical staff on wards. What is it that's been done differently of late then that has really impacted that engagement? Because that sounds wonderful.
Yeah, so thank you, Jill. I mean, it genuinely has been, I will say, heartwarming to see when Teresa, Justin and I have visited ED and wards. There is a palpable difference in levels of engagement. I think the root cause is the work that's being done by our interim lead divisional director for unplanned care, Claire Gowland, who has a ED nursing background as well as a very strong operational background. What she has been working on for the last 3 to 4 months is the really rebasing of nurse leadership in ED first and then in wards. So we've entirely restructured, for example, our site meetings and who attends them, so that they are attended by ward managers of each ward instead of more senior people. And so that we're having really gritty updates from those staff by encouraging them in a safe space to really step up and take ownership of their clinical areas. Not that that wasn't done before, but in the way that we're supporting the way that we move things on kind of through flow in each block of 4 hours that we're managing through the day and night. And the way that we have overtly made it the responsibility of the nurse in charge of ED on each shift to be fully responsible for the coordination of flow in the department in a way that you would have seen in the olden days before COVID, but not so recently in such a consistent way. And there's a number of other things as well as lots of process improvements. They are mostly fundamentals of care, fundamentals of good practice.
Can I just respond to that then? I mean, thank you so much for explaining that. I think what I've heard is a real stepped change to devolve responsibility and the positive response that there's been to that. So I really congratulate you on that. Well done.
Thank you. Like I said, we have I don't want to get people overexcited. This organisation, it can be hard to sustain these sorts of changes, but we are doing it differently than we have done it in my time here at the Trust. So that gives me more, certainly more hope and some more confidence that these changes will stick. But it's work on organisational culture is the work of years, not just weeks.
Absolutely, but completely echo Jill's comments that there has been some real, and I've noticed it too. It feels different at them these days. So very much our congratulations to the teams, for everyone that's been involved. One swallow doesn't make a summer, but it's at least a positive change. Right, let's move on. That we've got 2 more sections to do. Let's move on to finance. Martin.
Yeah, thanks, Chair. So in terms of kind of key highlights, as colleagues will remember, we've set a surplus plan of £1 million for 24-25, and there's a fairly chunky CIP programme that was a component element to that, and some large expectations around kind of ERF kind of growth and delivery as a contributing element kind of to that. As at month 10, so the end of kind of January, we're reporting a cumulative year-to-date deficit of £900,000, and that's just shy of £2 million of where we'd hope to be kind of at this stage. As we've talked about kind of previously, a significant element of that has been driven by a loss of income of industrial action kind of earlier in the year, and we've flagged that kind of repeatedly. In terms of the year-to-date position, there's a number of drivers behind that gap to plan. Certainly, we have seen some material shortfalls in our elective plan delivery across the year, and some significant gaps in terms of day case and inpatients have been a consistent concern across the years. We've struggled to mobilise activity capacity in the pace that we had kind of hoped. And there are a number of other kind of significant kind of cost pressures that we've seen arise during the year that haven't been kind of planned. Maternity has been an example that we've kind of quoted kind of previously. Despite those kind of headwinds and that current gap to plan, the Trust does remain confident at the present point in time that we will deliver the surplus plan at year end. I think a significant element of that has been the confirmation of receipt of EPR funding that we've had from NHS England in recent weeks. I think that's a product of ferocious, consistent lobbying that we've employed across a number of different offices across the year. So it's good to see that kind of come to fruition, and that will be an important element of how we get back to delivery of kind of the plan. The system continues to work tirelessly in terms of ensuring that it's not just us that achieves our financial markers by the end of the year, but the system as a whole achieves that, and that is something that is still somewhat kind of delicate at the moment. But I think there is some emerging confidence that we will get there. I think, as Adam called out in the Chief Exec's report kind of earlier on, a huge amount of energy at the moment going into planning for next year. And I know kind of board members will have been briefed just on Monday in terms of some of the challenges that will contribute to that, and what a difficult landscape it will be for us and the wider NHS in 25-26. So they're probably just the key messages I'd want to call out to kind of Chair, but more than happy to take any questions from colleagues.
Thank you, Martin.
Sorry, Chair. Oh. Can I just back? In about 2 minutes' time, we're going to switch back from generator onto mains power, and we might have a blip again. We have a problem with the synchronization gear, and we need to do this for clinical reasons. So it might be that at past, some people might get kicked out again just for a couple of minutes. So if that's okay, I'll let you know when we're back on mains power in about 10 minutes. Okay.
That would be great. Thank you, Kevin, and thanks for keeping us updated.
No problem.
Right, Richard, quickly, did you have any comments on the finance?
Yes, and I think the report highlights that too. I mean, while our financial position doesn't seem to be so far off target, the reality is this has been achieved largely through significant non-recurrent benefits, and this leads to a much worse exit run rate than we had planned for, which increases the challenge for next year. I think we've got some great reporting coming from the finance function here. So we do really understand what's the cause of these things, but what we have not seen enough is improvement over the last couple of months. So the focus of the committee is really on not just on building a solid 25-26 plan, but also the ability and capability to deliver this plan. And that's what we're going to be focused on for the next couple of weeks. And then in addition also, because the plan will contain some elements which have maybe some more difficult decisions underpinning it, the quality impact assessments or whatever is going to be in our financial plan.
Right, thank you, Richard. Any questions or comments for Martin? Kevin.
Thanks, Nita. Martin, I just wondered if this year there was any kind of NHSC reported data in terms of how we were performing nationally in terms of the levels of elective activity that we've delivered. I appreciate in the last couple of years in the pre-COVID comparisons, we've kind of been in the top 10 nationally, and I just wondered what our position looked like in 24-25 year to date, if that was available.
Yes, it is, and certainly you can share that for board members. I think, as you remember, Kevin, we were very quick off the mark, certainly kind of last financial year, in terms of really ramping up our elective capacity, of course, primarily to respond to kind of waiting lists and to achieve those reduced waiting times. But we were fairly successful in terms of making a financial margin on that work, and that contributed to our activity. So we were certainly in the top 10 performers in the country. Kind of this year we've kind of slid down that league table a little bit. I think not necessarily because we've done worse, but I think everyone else has maybe caught up a little bit and kind of recognised both the imperative of waiting list reduction and the financial kind of improvement opportunity that comes with it. So we're still a high performing organisation, but not in that top 10 that we've seen in 23-24.
Thank you, Martin. Thank you, Kevin. If there are no other questions on the finance part of the integrated performance report, I'll hand over to Tom for people.
Thank you, Anita. Hi, everyone. I'm Tom Pounds. I'm the Chief People Officer, and just a few of the points to highlight from the IPR report. So firstly, our vacancy rate, if you can see over the last 6 months, has continued to reduce from a kind of a peak of around 10% 6 months ago down to 8% as of January. So really pleased to see particular success, particularly around our nursing, where we'd seen towards the end of the calendar year last year, higher than I was comfortable with in terms of vacancy rates, but we've seen a real turn in that in sort of January and further in February, particularly as the newly qualifieds have been settled in and more positive recruitment, and equally with our care support workers. Our medical vacancy rates continue to remain low. Our priority is particularly around some of the scientific and technical areas where we've got some higher vacancy rates now, so more work to be done and thinking really differently about how we attract to some of those roles. In terms of appraisal rate, we're at 87% in January, so again very slow, but definitely improvement in getting towards that 90% target that we want to be at. We've got our Grow Together window opening again from April this year, so actually our work is mostly around getting people prepared. We've got kind of our Grow Together kind of champions set up in areas and really working with managers to make sure that they're giving every colleague kind of the best kind of review and objective setting process and all of the things that are great that are included within that process. And we're doing some technical changes to the system as well, just to make it a bit smoother for people. We've highlighted there some sickness absence because it has increased, particularly December, came down a bit in January, but still quite high compared to our target rate and where we need to be. Most of that work is obviously looking at where we've got the hotspots, the higher levels of sickness, working with the managers there, and again, coaching conversations around making sure we're doing all the basics, essentially around return to works, following up with kind of our sickness review processes, and obviously using our kind of health at work services to support staff to be kind of well in work. The positive side of that, though, is that when you look at some of the breakdown of sickness, things like mental health related absence and particularly musculoskeletal actually has showed continuous improvement and actually much better than where we were at this time last year and previous years. So we're pleased with that part at least. Final bit was around sort of the National Staff Survey. So we have results that remain under embargo at the moment, but that means that we can be doing the really important planning work to make sure we're ready when the results do get launched later in this week. And that will include things like kind of an all-staff briefing and a letter going out from Adam. We are working with we will be working with divisions to do kind of divisional briefings. We've set up a template called our Team Talk template, which pulls out by each of our care groups and some of the specialty areas what the key priorities are, and so we can quickly work on developing those local action plans and support the delivery of kind of the improvements in staff survey. But we're really pleased this year that we had over 50% of our staff responding. I think that means that we get results that really tell us about people's experience in this organisation, and we're looking forward to obviously sharing those later with the board at the next board meeting.
Thank you, Tom. Janet, Chair of People and Culture, anything you'd like to add to Tom's report?
Thank you, Chair. So there was a couple of things for me. One was around the vacancy. So obviously our headcount is increasing and is kind of keeping increasing, and that we can see that pattern in the report. And I think we are making progress around agency and bank staff as well, Tom, but I think it would be interesting to try and triangulate those things more in a way that would actually tell more of a story so the board can really understand, particularly when we take that in conjunction with Teresa's report around skill mix, because for me they're sort of treated quite separately and that makes it a little bit more difficult to understand. And then the other piece was really around the diversity and what you're doing around interviews, etc., and whether there's an opportunity there, particularly targeting those areas where maybe you are struggling to fill roles, looking at what could be done, maybe to pilot something that might work. So looks like there's lots of good opportunity for managers to pick up different ways under the kind of more than just an interview banner. But it would be helpful, I think, to maybe try a few things and actually see what might work. It might be helpful. Otherwise, yeah, I think good progress.
Thank you, Janet. Diana.
Thank you, Chair. Tom, you mentioned that that the number of kind of cases for disciplinaries and they're going down and the grievances are going down, which is all good. I'm just wondering, are we capturing a lot of that learning? So because obviously there are a lot of areas where things like discrimination were quite high in terms of the reasons behind some of the disciplinary grievances and so on. And I'm just wondering whether we're capturing that learning and we're using that to help us to make improvements going forward and to just use it as more of a preventative approach to what we do.
Right, shall I come straight back in, Anita? Yeah, great. Thank you, Diana. I'll respond to that and I'll just pick up on a couple of Janet's points as well, if that's so okay. Yeah, absolutely. We have a learning approach to disciplinary and grievance processes that we have. They're particularly ones that we've got that have got to the point of kind of employment tribunal as well. So we'll do a deep dive into a particular case to understand kind of what led us to that point, what were the contributing factors, what were the opportunities for learning. We've invited obviously people that have been part of the process to give us that feedback. We've really taken on board the learning that the HPMA led with a trust in Wales, actually, which was a principle of do no harm. That particular organisation had a really high number of cases compared to the number of staff. We're not at that same level, but we certainly can't exclusively say that our processes aren't in some way causing some sort of harm, whether it's you're the person that is being investigated, whether you're the investigating officer, sometimes the HR support staff, it's quite a burden as well to manage some of these cases. And so, we have to recognise, if we don't pause and get things right at that very early outset and ask, is it absolutely necessary that we're taking a formal approach here? We could be inadvertently causing harm to several people. So that learning's been done, with the employee relations team, with our business partners. We've done a session actually as an executive team to talk about some of that information, and that's starting now to be taken out to the divisional boards as well for more discussion. So that's certainly the kind of the learning and reflecting that we've done from national work in with the departments, but also, like you say, we do kind of case conferences and look at particular cases and do the learning of those as well. And we really do hope that we continue to see both the volume of kind of formal cases going down, but equally, if we have to go into formal cases, making sure that we reduce the timeline for those as much as possible. Just on the point that Janet raised around the triangulation between substantive bank and agencies, absolutely the right point. And Martin mentioned the planning round this year. That it is really crucial that we're getting the workforce numbers aligned with the financial numbers, and part of that is to make sure that we've got that really close triangulation with the impact around what are we expecting in terms of the budget, and all of the things that impact on that whole time equivalent, what we're expecting to deliver through our recruitment pipeline, what therefore the impact is around the use of temporary staffing and agency, and we're clearly committed some big reductions around bank and agency for next year to deliver that. So as that plan is obviously really kind of being worked through at the moment, and we had some high level details being taken through FPPC only last week, as we keep to kind of crunching those plans, there'll be far more detail that we'll obviously be able to bring through to People and Culture Committee.
Thank you, Tom. Martin.
Yeah, it was just to build on that a little bit, Tom, to get a few of your thoughts on there. So as we come to the end of this year, you are probably using 200 or so more staff a month in February than we were in April on there, and so that inexorable kind of climb in terms of the headcount, and an expectation that very much that goes into reverse next year from a national planning perspective, and rather than growing by 200 or 300 staff, that are expected to reduce by 200 or 300 staff, which is going to feel very different. Sort of on then, I wondered whether you could say just a little bit more about some of the different strands of work that I know that you and the team are leading on, but we'll need to deliver collectively as a trust to do that in a sensible and a planned way, rather than in a way that kind of promotes concerns around quality and safety.
Yeah, no, it's a really valid point, and yeah, it's a really challenging planning period, but there's absolutely opportunity for us, and I think that's worth kind of acknowledging and recognising. So from a range of things, both looking at kind of where there's been kind of growth in establishment over the last few years, and we would look across the whole organisation, but particularly in those kind of support to clinical staff kind of areas. So that's corporate led teams, but also support to clinical staff teams, and looking at that kind of budget growth and how we're reviewing that over time. We obviously have an opportunity around bank and agency to say, where have we got kind of active recruitment and targeted recruitment to reduce that? And if we haven't got active recruitment going, why are we putting it through temporary staffing? We should have enough within the headroom to be able to manage that. We've got other kind of skill mix review opportunities by kind of just working differently. So looking at where things can be more centrally led, consolidated, looking at kind of much more standardization of kind of practices. So that's kind of in there. We've obviously got things around kind of digital innovation and improvement, which will enable us to kind of look at kind of workforce structures and how they're set up in a different way. The One EPR, which we've already had presented, being one of those kind of opportunities which will change the way in which we work, and mean that kind of we'll plan very carefully around how that will impact the budgeted whole time equivalent over time. So yes, absolutely, we will be seeing that budgeted whole time equivalent come down. We have an absolute expectation that we already have a kind of a buffer of kind of headroom with our temporary staffing and agency usage, which gives us the ability to bring that down over time as well. So yeah, lots of work going on that we'll bring through in far more detail, likely through both finance performance and people and culture.
Right, thank you, Tom, and thank you for the question. I am very, very conscious of time, but Richard's got his hands up. So Richard, quickie, please, and then we need to move on. Thank you.
I'll keep it short because it was basically on the same theme. I just wanted to express a slight concern. I understand, Tom, what you said. I know the work that's been going into this for next year, but for me, mathematically, it just doesn't compute right now, because you have explained the vacancy rate went down significantly, actually, when you look at it, supported by attrition, I would think. But I don't see rank and agency go down in the same balance, right? So, and that just doesn't work. So we really need to understand this better, is my point of caution.
Yeah, no, I understood. I mean, we have seen the agency come down. Our proportion of agency as of our overall pay spend is certainly significantly lower and benchmarks exceptionally well, I would say, across East of England. Our challenge is around that bank. So in terms of controlling the cost, moving from bank to agency to bank is positive. We really need to see that from bank to then substantive, and that's the bit that's taking us a little bit longer. And I think we're not going to do it by doing the same things we've done over the last couple of years. We are doing something quite differently now around kind of skill mix and the way we work to make that next kind of significant change that we need to happen.
Yeah, absolutely, and yes, it's a really important step. Right, thank you very much for to all colleagues for the integrated performance report and the questions that we've had. I think if we're happy to take that as it's for noting effectively. So thank you. Let's move on then. Now, can I please ask everyone to keep things relatively concise, given the time we have available? But obviously, we do need to give everything the right, due consideration. So next thing, board assurance framework. Stuart.
Thank you. So my name is Stuart Dalton, and I'm the head of corporate governance. Taking the paper in two parts. So the second part is on the spotlighted risks, which I'll come back to. The first part relates to the other 10 risks. For these, I'll take the key updates as read. Before I open up for questions, can I just double check the board agrees with FPPC's recommendation that the risk scores for the investment and financial constraints risks should increase from 12 to 16? Okay. So
we get nods around the gallery. I think we do, Stuart. So I think the board is comfortable that that is appropriate at the current time. Thank you.
In which case, then, for those first 10 risks, I will open up to any questions.
Karen.
Thank you. I'll keep it quick. I think over the course of the last week, we have looked at the planning round, and I think as part of that, there's been a lot of quite innovative work that's been taking place across the organisation to come up with thoughts and ideas. A lot of that seems to entail digital. So when I was looking at these 10 areas, it said in terms of digital transformation, it's envisaged that the creation of a dedicated digital committee should help drive the risk score down. I agree that it will help in terms of one EPR, but my question is, if we are going to hit what we need to hit for next year in terms of the productivity challenge, and if part of that is digital, is that an area that we are going to really need to focus on this year? So I guess it's a question for Mark, and I'll stop there first and then I'll come back. I'll let Mark respond. Thank you.
So Karen, yes, and remember the digital committee also includes outpatient transformation, which is a large-scale piece of digital work. So both outpatients and both outpatients and one EPR are both budgeted for in terms of digital resource. But I agree that there are other areas that will require niche skills or additional skills that would have to be an investment in terms of there. So there'd need to be obviously a return on investment for each of those.
And it was just a comment and a very quick question in terms for you, Stuart. So again, just reflecting on all of the change that needs to happen next year, the productivity gains we need to make are quite sharp as they are across all of the NHS. And I think that's just really important for us. I just think that it would be good just to reflect upon each of these risks just in the context of what we're aiming to do next year. So if you agree, Stuart, in the interest of speed, I suggest we pick that up at the audit committee on the 1st of April as well, just as an area to discuss these initially.
Absolutely, and I'd also make the point that we are having an April board seminar where we're reviewing the entire BAF. And I've already been having discussions about broader digital risks as well.
Absolutely. Conscious that we have got that board seminar coming up. Nina, are you okay, or was it a question you wanted to ask now? You are okay.
It's fine.
Oh.
It can wait. Thank you.
All right, thank you very much. We are going to have a full discussion about the BAF and consideration of some of those things. So I think just coming back to you, Stuart, in terms of the 2 spotlighted risks that we had this month, this board, was there anything you wanted to draw to our attention, or any decisions or actions you wanted us to take today that we need to do?
So usually, but conscious that we've got limited time, I'd usually be handing over to Tom. I think the key point is that we're actually getting staff survey results, which are so pivotal in this. So it may be one that then comes back to a further discussion, but I'll pass to Tom.
I was gonna, you said the words right on my mouth, Stuart. I said that, I mean, the one of the things of this that we discuss each time is is it 16? Should it stay at 16? We've always said, well, the staff survey results haven't shown us enough to show that the controls that we're putting in are yet having a difference, and we've always recognised this is one of those ones that takes longer. We're kind of looking at this a little bit in abstract at the moment because we haven't got the staff survey results in front of us. So I think that's probably the best control and indicator that we have, and so I think looking at it then would be better, which would time well with the board seminar session. The other spotlighted report is the accountability one, and again the discussion there, probably better for the board seminar, is about the need for that when we've got the culture spotlighted risk, and we've got one around the E&H production system, when one of the core principles is around kind of autonomy and accountability, or the understanding of devolved autonomy. So again, I feel like they are probably best to be explored in that forum.
Thank you. So thank you, Tom. Thank you, Stuart. This paper was for discussion. Karen, you wanted to come back in.
Yeah, apologies again. And just in terms of autonomy and accountability, I'd agree that the East and North Herts production system is one of the areas that can lead to mitigation. I think I would challenge that it's the biggest, and I think the need to look at autonomy and accountability quite quickly is something that's quite important for next year as well. So again, Anita, in the interest of time, I think we'll pick that one up at the audit committee on the 1st of April. Thank you.
Yes, we will, and indeed that's also central part of the discussion at the board seminar. So that's absolutely on the agenda. So yeah, if we go to hold that one, that would be brilliant. Okay, thank you very much then, and thank you, Stuart, for that paper. Let's move on then to nursing and midwifery establishment. Is that you, Teresa?
Thank you, Chair. Teresa Murphy, Chief Nurse. So I'll be brief. Hopefully the paper is comprehensive and clear, and what the paper sets out to do is provide an evidence base for safer staffing with some caveats. So midwifery staffing is managed through a different route, through the Birthright Plus review of evidence, and theatre staffing through a different route, and so is children's staffing. So what we have here is a comprehensive report on acuity and indeed safer staffing across the lens of the Safer Nursing Care tool, professional judgment, and also through our care hours per patient. So I will take the report as read, but what I would just like to strengthen to the committee is that this report, as is, has been through the Quality and Safety Committee, and we also have underneath this report an operational oversight 4 times a day across all of the domains around safer staffing. Ward managers meet every Tuesday, and with myself, and we cover safer staffing routinely. So whilst this is a benchmark point in time piece of work that looks at April 2024 and indeed August 2024. I would just like to endorse that the board will see this at regular intervals as stipulated by yourself, Anita, as our chair, but it's really here for discussion and assurance purposes. Thank you.
Thank you. Any questions or comments for Teresa on this paper, please? No, I don't think it's a oh, Adam.
Sorry, just very brief. I'm linking to some of the previous conversation around the need to drive down workforce numbers, which can feel jarring against kind of national frameworks if you've got to demonstrate the numbers. And I don't think it's a local connection issue. I think it's a national challenge between the desire for good levels of staffing versus the tighter financial control. So I think more than ever going into next year, we're going to have to be really very explicit throughout previously kind of referenced quality impact assessment work, and also making some judgments about the risk we hold. But we need to be very transparent and cognizant of that in our decision making.
Yeah, absolutely agree with that. Jill.
Sorry, using the wrong clicker there to not unmute myself. I just want to make a comment, if I may. Obviously, it's been mentioned that the Quality and Safety Committee looked at this paper in detail, but comparing it with the work and approaches being taken elsewhere around the country, I just wanted to state that I think this level of detail provided by Teresa really does assure us of the very robust approach being taken under her leadership to ensure that safety is optimised for our patients with very varying clinical demands. I think it's a really outstandingly detailed report.
Thank you, Jill. I do think it's a great report, so I agree. And so thank you to Teresa and the team for having produced that. It is for discussion, so we don't need to approve it or anything. But thank you for that paper. I'm going to suggest that that system performance report, we just take that one as read and move swiftly on, unless Martin is desperate to talk to us about it. I assume not. So I wondered if we could go to the committee reports. I am conscious of time and I apologise for my poor timekeeping, but we did have a very detailed discussion on the IPR this time, which I think has eaten into our time a little bit. But I would be grateful if the chairs of the committees could draw to our attention, particularly the alert, but also other things that you think as a board feel should be drawn to our attention. So can I ask Karen first, the Chair of Audit and Risk? Thank you.
Okay, well, I'll take the report as read, but to highlight in terms of the duty of candour that the three chairs of People Committee, FPPC and myself have met, and we've worked with with Margaret Mary, our Director of Quality, to actually produce a draft brief. We're expecting that shortly, and we're targeting looking at a bit more of a cross-cutting piece of work, and this is all about compliance and accountability. This is the real drive that we're putting into it. So it was just to flag up this cross-cutting piece of work that we are beginning on, and I think it will be an interesting piece of work for us and an interesting experiment to report back on. Otherwise, the only other thing I think that I would want to highlight is the assurance that we've had from internal audit in terms of our risk management processes. I think I and other members of the audit committee think there is still more that we can do and would like to do to improve, but it is really good to have had that assurance. So thank you.
Thank you, Karen. And yes, completely agree on both those points. I think the duty of candour piece of work is really innovative. I've not seen that anywhere else, and I think that would really look forward to seeing where that goes. And likewise, the comments regarding the assurance level provided by internal audit. Any questions or comments for Karen as regards the work of the Audit and Risk Committee, which is summarised in that report? No? Thank you very much, Karen. Can I move on then to Richard and Finance, Performance and Planning, please?
Thanks, Anita. I think the report speaks for itself. The most important alerts have been in the discussion already. The only thing I would say is that everything that is an alert or an advice, there are next steps on these things. So we will be focused on this going forward.
Thank you, Richard. Any questions? Jill?
May I just ask Richard, I was really keen to see that the committee had considered consultant job planning, and I did look at the papers with regard to that. I just wondered, as this is such a critical area in terms of meeting qualitative financial activity related challenges that we have, whether you felt that sufficient qualitative or measures of success other than the planning's been reviewed had been identified for this project?
Not yet. That's why we've also requested it to come back in our monthly meetings, Jill.
That's helpful, thanks.
Thank you, Jill. Thank you, Richard. If there are no further questions for Richard, let's move on to quality and safety. David, what would you wish to draw to our attention, please?
Thank you. I think the report is self-explanatory. I did, for completeness, really include an alert around the HSE, but I don't think the board needs to be concerned it will be resolved or completed very shortly. I think the board might be interested in the future that hearing from the enhanced nursing care team. Not every hospital has such a team. We did think it was very useful hearing from them, and we do think they contribute to patient care. However, whenever you introduce new roles, it causes new interfaces and new issues. So I think it's just a general issue for the future about patients. People are a bit confused about all these new roles that we're creating. It is inevitable, isn't it, that we will have to do this because staffing is an issue. So I just thought I would raise that one for the future.
Thank you, David. Any questions or comments for David on the QSC report? No? Okay, thank you. People and culture, Janet.
Thank you, Anita. Just to say, I think the alerts and advisory bits on this report, actually, we've discussed already in terms of things like recruitment, bank and agency, etc. And we're aware that we're waiting for the staff survey results. I think the only other things we'd say, we're continuing to refine the way that the committee's operating. It will be operating in person next week for the first time, I believe, which will be good. And we really welcome the establishment of the Equality and Diversity Steering Group that sits beneath it, and really working out how to make both of those work in harmony with each other. But otherwise, I'm quite content. Thank you.
Thank you. Any questions or comments for Janet? Jill?
Just a simple one. I didn't know whether there was an omission from the escalation report with regard to assurance.
Yes, the section was blank. So was there supposed to be something in there, or no, there wasn't anything? You haven't got any assurances this time?
No, there weren't any at this point, no.
Yeah. Okay, thank you for that. Okay, moving on then to charities. David.
Thank you. Very brief report. I think my summary would simply say that the charity is doing extremely well, and fundraising is progressing, and I'm glad that we're all going to be going to the Far Walk in a few weeks' time.
Thank you for that. Right.
And the abseil.
Oh, and the abseil.
And the abseil, yes. Thank you for reminding me.
Right. Any questions or comments for David and the charity? No. Thank you, all of you, for your reports. Moving very quickly on then, in terms of other items, the annual cycle is in the pack. If anyone has any concerns, please let us know, let Stuart know, and we can move things around. In terms of any other business, first of all, Ivana Charmer from Health Watch has been here through the meeting. I wondered, Ivana, if you had any questions or comments for the board.
Thanks very much, Anita, and also thank you so much for welcoming us into the space. It's fantastic to be able to observe and learn about how the Trust is working. Just one reflection, which was about the strategy document. I noticed with great positivity being Health Watch that there was patient voice being embedded in the core metrics of consideration of that, and also working in partnership. But in the partnerships section, I noted that it referred essentially to clinical partners, but I wondered whether or not there might be space where it's appropriate, and I appreciate this needs to apply to all staff, to consider how we intersect with things like the voluntary sector. So just a little bit of food for thought, because I think from moving, from hospital to community and so on, these conversations are happening a lot in other spaces I'm privy to, and I think recognising that in some of your strategic documents and plans might be really worthwhile. So that's it from me on this occasion. I appreciate the opportunity to be here. Thank you.
No, thank you, Ivana, and that's a very interesting reflection. I'm sure Adam, Ailey, and the whole team will absolutely reflect on that. But I think it's an interesting idea and not something that we've done. So thank you. Moving on. So the only other bit of any other business I have to say is, as I think everyone on this board knows, this marks the very last attendance of Tom Pounds, our beloved HR CPO, who is moving on to pastures new at the end of this month. We're very much, very grateful for all the work and all the leadership that he's given this organisation, and he will be sorely missed. And I know that the Trust will be saying goodbye to him formally on another occasion, but wanted to mark his contribution, and as I say, we'll be sorry to see you go. We're also delighted, of course, that Amanda, who is here as well, Amanda Harkes, the Deputy Chief People Officer, will be acting up following Tom's departure, and so will be our primary point of contact after the 31st. But thank you very much for your contribution, Tom. Apologies again for the fact that we are 6 minutes late, but I hope we've had a good discussion today. Our next meeting will be in person. It's on the 14th of May at Hertford County. Thank you again to all members of the board and guests for their contributions and attention. And I hope you all have